smack in the middle. If you take a line like this and a line like this, and it's sitting there, and it's probably about the size. It's kind of a squashed baseball almost. Okay.
Oh my goodness.
Maybe a racquetball, but it's pretty big. It should have surgery. As you get older, the risks of surgery certainly go up. But just talking with you here, you seem like, you're overall cognitively pretty good still, and this is something that we would recommend surgery for. Otherwise, we're going to see continued progression. We don't know the exact time course. Like, I don't know if this looked the exact same 10 years ago, I'd say, well, maybe don't do anything. But I doubt it did. That's not what we typically see with these. Some of the smaller ones and medium-sized ones can stay stable over time as you get older, but this one's pretty big. There's also an aneurysm, which is now patching on a blood vessel. They are also not rare. They can be small or big, or just kind of medium size, and they have a risk of rupture, so of rupturing and bleeding, and if that happens, that can be fatal at times. And so if we find one, we always have to consider, do we need to treat it? Do you smoke, or did you smoke ever? Do you have any family history of aneurysms or rupture? And I know there's this possibility of Ehlers-Danlos that
I had an aneurysm in my aorta.
Thoracic aorta, and that was
her brother
repaired,
died
right?
from an aortic aneurysm.
From an aortic aneurysm. So maybe there's some underlying predisposition. I don't do aneurysm surgery anymore. It's been many years since I have, but I have a few partners that do, but I do a lot of brain tumor surgery. I would talk to my partner and see what our plan should be in terms of treating this. So looking at your scans, so some aneurysms they can treat through the blood vessels, and that's ideal. They can do it very minimally invasively.
Oh, really?
But some aneurysms need open surgery to treat. And so I want to discuss with her, my partner, about what would be best for your aneurysm. If we're going to do open surgery, then we think about sort of combining both, okay, to address both, and that would be the reasonable way to go. If she feels like she can treat it from the blood vessels first, then maybe have that taken care of first and then treat the tumor. To treat the tumor, there's a couple different ways, and you're right-handed again, correct? So we would typically, and again, depending on what we decide for the aneurysm, but make an incision across the top of your head, take a big piece of bone off. If we didn't have to deal with the aneurysm, I'd typically just come from the right side, which is away from the side that controls speech and language function, slip under the brain here, go along the base of the tumor and basically cauterize it, detach it from the lining that it's coming from, and then piecemeal, like break it up into pieces and take it out, and then close up nicely. Anytime we do surgery, we have to talk about the risks, and risks of surgery include things like infection, bleeding, very serious things like coma or stroke or death or paralysis. Those risks are very small but not zero. Those risks do go up with every decade. When you're like 80 and you're a young 80-year-old, especially cognitively, it's still it's harder on you than when you were 60 or 50, for example. There's some recovery involved. There's some chance of other problems, heart problems, lung problems, blood clots in your legs or lungs, a chance of affecting your vision. If you have any sense of smell, it's going to be gone after this surgery. I can't imagine that you would have very much right now, because the tumor is where it's growing should have basically obliterated your nerves that control your sense of smell. So maybe next time, if you have some coffee grounds, I used to actually keep some here. I don't know if we do anymore, but we used to have you smell them to see. But next time, try and smell some coffee grounds, see if you can actually smell them, okay? And let me know that. The other options, you could go straight to radiation. With this size tumor, most of the radiation doctors wouldn't want to do that. We usually save that as a secondary option if there's like a small amount of tumor we can't take.
Like we did with Jim.
We did for Gamma Knife.
Yeah.
And this tumor is partially, slightly, looks like eroded through the base of the skull, and that can make the repair a little bit more complex when we take it out, because it erodes down into your nasal cavity. It hasn't quite started going all the way through, but the bone looks thin. And
Question. She has been having, it's not like a bloody nose, they almost look like blood clots coming down out of her nose.
It's probably not related. Yeah,
okay.
Probably not related.
I think it has to do with the psoriasis.
I took her to a dermatologist though, and he said she didn't.
It's blood clots though, huh?
No, it's bloody mucus.
Bloody mucus, okay.
They dry and they look like little dried blood clots, yeah.
That wouldn't be like anything related to the brain or the tumor. But this tumor, so when we take it out, there's a risk of getting even a tiny hole between the cranial cavity and the nasal space. And so typically, the consent, I'll have possible extraventricular drain, so I can put a catheter in your head to, your brain is always making fluid, and we divert it for a couple days after surgery. And I might have to take some fat from your abdomen to help in that repair that we do.
Plenty of that
Just
for
a,
you.
just a little bit. And there's ways we have of repairing that, a hole if we get a little hole there, so, okay. And then there's some recovery involved. You know, if we just put you under anesthesia and didn't even make an incision, and put you under anesthesia for 6 hours, you would be very tired for weeks to even months after surgery. You would be cognitively worse initially too from the anesthesia for the first few days at least. And you know, even some older people, like, they won't talk for like 3 or 4 days after surgery just from the anesthesia, and then then things start turning around, you know, and they come back.
So is the recovery gonna be a concern because she already has fatigue issues, like she sleeps a lot during the day right
Probably
now.
16 to 18
right
hours
now.
a day.
So I know, like, for me, after the surgery, fatigue was, like, it took a while to
Well,
kind of get.
I watched his
back.
recovery. It's a big recovery.
That's exactly what I'm referring to, and that's when I
Yeah.
say things are harder when you're 80 years old.
Yeah.
Everything's harder, right? And so, you know, you don't have to have surgery. The way I practice, I'm always going to tell you what I would want for my own self or my
Right.
loved one if they were in your situation. I think,
Right.
you know, I think if you had a lot of like terrible medical problems, we were really concerned about your ability to get through surgery, I would say maybe don't do it, but I don't know that you have that.
Okay.
Yeah, you know, like terrible heart problems or like, you know, like an unstable sort of heart, you know, or, but I think that,
Okay.
but the age makes a difference. Like your recovery is going to be longer. It could be 3, 4, 5 months afterwards, you know.
Okay.
So just,
Okay.
it depends on the individual though, because,
Sure.
you know, I've even had like 90-plus-year-olds who've gone through this kind of surgery, and I still remember one who was like 36 hours from surgery, was ready to discharge home and just felt great,
Yeah.
you know, and it, so everyone's a little bit different also, but I imagine
Okay.
it's going to be a longer recovery for you
Well,
with the underlying issues.
And I'm concerned because I have watched the decline over the last couple of years. I mean, she got tired, she had to stop and sit down. Just, you know, we dropped off right at the front then in here, and if we're having trouble, you know, just with walking and things like that,
Well-
and sleeping 16 to
Well-
18 hours a day, how are we going to do with this?
You've had some shortness of breath, right, too, so we're gonna ask for a formal cardiology evaluation too, and get a cardiology evaluation and a medical evaluation. We always do that before surgery too, and just, especially the cardiology, if we're concerned about chest pain or shortness of breath. I know you don't have chest pain, but just to make sure your heart's safe for surgery, okay?
Yeah. The other concern
So-
that I have is when she had that aortic aneurysm and they replaced it, they put her under, they lowered her body temperature, they brought it back up and then brought her out, and I feel like part of her never came back.
Yeah, and that does happen. When
And
was that done?
8 or 9 years ago.
That's a big stress to the system when that happens.
Yeah.
And there are often little hits to the brain that occur, tiny strokes that don't even get picked up. They're so small, but they can cause some problems.
And that's the
so,
big concern I
yeah.
have, is even more than surviving the surgery is
Yeah.
what is it going to, quality of life afterwards.
Yeah. My goal is to keep you as you are, you know, and I think there's a very good chance of that, but there will definitely be some recovery involved. So, yeah. Now, if you all think about this and you say, look, I don't want any treatment, I mean, that's, you know, I just want you to be able to make an informed decision.
Yeah,
So let us
Absolutely.
know,
I'd
right?
probably need a little
Absolutely.
more information
Yeah.
to,
We're obviously
Yeah.
going to respect that
Yeah.
decision, but I would say there's a big tumor there. You overall still seem pretty good. I mean, I would favor sort of taking it out. You know, the aneurysm, it's 6-7 millimeters. It's on the larger side, so even if you didn't have the tumor by that size, we'd probably lean towards
It's 6 or 7
millimeters. Yeah, which is, you know, I think generally an 80-year-old, I think they would sort of also present you the options and say, well, we could watch this, but you know, there's some, you know, rupture can be fatal very, like, immediately. You know,
Right,
and
see,
so,
that scares me, because that's
Yeah.
what was with my brother.
Yeah. So, okay.
Just within a matter of a couple hours.
Do you have a sense if you want to just think about it and let us know, or do you want, if we start the process, you're not obligated to anything also, but I think that, you know, we should probably start the process if you're at all thinking about surgery, because we need to get all these clearances
Sure.
and all this other stuff, you know, so.
I mean, I would say let's do
Yeah,
that.
yeah.
I mean,
Yeah, I'm
and then
sorry
we will
about the
talk about
aneurysm.
it.
Yeah. I mean, the chance of something happening, you know, your chance of like having something happen between now and the surgery with the aneurysm is, I would say, very low. I mean, it's not zero, but you know, it's very low. Okay, on a day-to-day basis, but you know,
if we decide to have the surgery, what kind of a schedule are we looking at?
It's like before, it's usually 3 or 4 weeks out.
Okay.
I would be doing, if we're doing the aneurysm surgery as part of it, which I'd kind of lean toward just getting it all done at once.
Yeah, I
And
can't even imagine twice.
We wouldn't do it twice.
Yeah.
So we'd probably involve one of my vascular colleagues for that part of it too. I've actually done a whole lot of aneurysm surgery in my life too, but we're very specialized too now. And
Sure.
so, when we got here, I said, well, I'll take care of all the complex brain tumors, and you
Yeah.
guys do the aneurysms. And so
So,
it's not, but I would have them involved for that part of it, and then so I'm guessing probably like 4 weeks out or something.
so
like
we're
that.
looking at probably like early June.
Yeah, something like that. Yeah.
Okay.
We have to make sure we have time, and
Good.
it'd be probably
What's
most of the
recovery
day.
time?
It'd probably be in the hospital, so there'd be that drain in your head.
A long
I'd probably
time.
guess about 5 days in the hospital, and then back to the facility you're in, or if they thought you needed rehab or skilled nursing for some time, maybe there
The
for a little
reason I
bit.
ask is Dome, I know, but we have a family reunion.
You're not
Well,
going to be
when-
at the
when is
family
that?
reunion,
21st
Mom.
of June.
No.
No, that's not gonna happen.
Oh. Well, where is that located?
It's in 6
Utah.
weeks in St. George, Utah, at
Yeah.
altitude.
Yeah.
No, that's not happening.
Well,
Just remember,
but I let you all
I'm just
debate that,
saying,
so
I'm
I-
just saying, I've lived this, and Jim worked out for 3 months before his surgery.
I wouldn't have made it.
He was
to
in
that.
Yeah,
in
no,
incredible physical
No,
shape,
I'm only thinking
and
the
he was
only
in
thing
no
is that
no position to go anywhere.
the only
a couple
thing is
weeks
I'm saying
after
is like
surgery.
if we did the surgery after that. Then,
Oh, yeah, yeah.
Then that's a possibility because
delay
it's
it.
been a long, slow process. I am out of town for a lot of July. We're
Right.
going overseas for some time. I wouldn't want to do your surgery and then immediately. Although if my partner's around, like, and she helps me with the surgery, she'd be there to watch over you. But typically, I want to be around for at least the first part of your,
Yeah.
recovery. So yeah.
Right.
So
Right,
okay.
yeah,
All right.
so,
We'll get your.
I think the family reunion is immaterial in making this
It probably
decision.
is.
Yeah, I mean, for all of
Yeah,
us.
yeah,
I
yeah.
mean, as far as our going, you're going,
Yeah.
that is pretty small on the list of concerns.
yeah,
Yeah.
All right, well, we'll get the paperwork going. Let me talk to my colleague now that I've gotten a chance to meet you, see what's going on, and then we will, and if we're gonna do the aneurysm too, at least have her do like maybe a virtual visit with you or something, you can
Sure.
check in, and maybe you could all attend that as well, so.
Sure.
Sure.
Okay,
Sure.
all right,
Okay,
good, you're doing
Yeah.
okay?